We're going to go ahead and get started as people are making their connections. I'm really pleased to welcome you to the start of the 2021 Maine Wisdom Summit. This is the first of two pre-summit sessions, embracing trends and advances in technology and information sharing to support healthy aging. I'm Jess Maurer, the Executive Director of the Maine Council on Aging, and on behalf of the Board of Directors and members of the Maine Council on Aging, it's my great pleasure to welcome you to our kickoff event. Before we get started, we want to thank our presenters, planners, sponsors, and exhibitors for their support of our 8th annual summit, our second virtual summit. They make this event possible, and we are so grateful for their support. I am really pleased to announce our exclusive premier keynote sponsor, which is United Healthcare. Their support makes it possible for us to bring quality speakers like Louise Aronson to our event. Their active participation in the MCOA makes our work so much more productive. Our exclusive Summit Award sponsor is Andrew Scoggin, Home Healthcare and Hospice. We are so very excited to honor our award recipients at our annual meeting and at the summit on the 21st. We hope that you'll be there to hear all about the wonderful people who are receiving more awards from us this year. Our platinum sponsors are Aetna, Alpha One, GT Independence, the Maine Association of Area Agencies on Aging, the Maine Health Access Foundation, one of our award winners, and Sensio Systems, Inc. Our gold sponsors are A Helping Voice and Community Health Options, the Maine Community Foundation and Healthy Living for Me, Maine Health and Martins Point Healthcare, McKesson and Northern Light Health, and Seniors Plus. And thanks to the rest of our 2021 Wisdom Summit sponsors. Our sponsors, someone muted me accidentally. Our sponsors make it possible for us to keep costs low for people to attend this event. So please make sure to visit them to find out more about what they do. And if you would you please join me in giving these sponsors a virtual round of applause. And you can actually use reactions to give a nice little reaction as well. So thank you. We also want to thank our Wisdom Summit Planning Committee for helping make this event a reality. These folks have been meeting since January to design the theme of the summit, to identify speakers, and really to generally put the flow of the summit together. We are forever grateful for their work. Again, please join me in thanking them virtually. Most of all, thank you for joining us today. While we may not be together in person, our cause is united and collaboration is essential as we work together to build an age-positive culture in Maine. Just a few housekeeping notes before we get started. All of the participant lines are muted, but you will be able to participate using chat today. We want to hear from you, so please don't be shy. During the event, you can enter your questions and comments anytime into the chat box, and the chat box is located at the bottom of your screen. We're going to test that out by having you introduce yourselves. Just let us know who you are, who you represent if you're with an organization, and where you're located in Maine. And if you're experiencing any audio difficulties, please send an email message to info@mainecouncilonaging.org or just chat a message and we'd be happy to assist you. With your email today, you will find the agenda as well as the virtual summit FAQs for attendees for more detail and information. A link was also included to all of the speakers' bios. We won't be introducing them extensively today just for timing purposes, but please do check out their bios in the link that was provided. Finally, we'd like to take a moment to apologize for our error and insensitivity in scheduling this event during Rosh Hashanah, which is a high Jewish holiday. We are committed to including everyone in our events and have intentionally avoided this conflict in the past. We got it wrong this year, and we're really deeply sorry. To ensure access to all, the event is being recorded and will be made available for free as soon as the recording is available for those who were unable to join us. So let's get started with the program. The name of our Wisdom Summit this year is Embracing a New Normal, Bouncing Forward to Build an Age-Positive Culture in Maine. COVID has really changed everything. It exposed deep-seated ageism that let us all see clearly that some people think older lives mean less than younger lives. We'll be talking more about age bias at the summit, and I certainly hope you join us for that important conversation. It also fast-tracked many things, especially the use of technology in Maine. We began using technology more than ever to deliver medical care and behavioral health counseling, to connect older people to their families, to reduce social isolation, and to bridge significant workforce shortages. Despite many of the stereotypes some hold, most older people have embraced technology, and we're now looking forward to what's next. This is why we don't want to go back to what's normal, the way things used to be. We want to use COVID to bounce Maine forward, and technology will be a big part of our future. So will coordinated and curated information sharing. With fewer workers, volunteers, and resources, we need to work smarter. We need real-time information sharing between medical and community providers so that if Mrs. Jones goes to the hospital, her home care worker can be diverted to someone else who needs care, and her home-delivered meals won't be delivered until she comes home. And if a community has a community paramedicine program or a community nursing program or just a friendly visitor program, wouldn't it be awesome if someone knew that Mrs. Jones was being discharged and was there at her home to help with a safe transition? We aren't there yet, but you'll hear about how we're moving closer to this goal. Today's session is going to be a bit of a smorgasbord. I really just wanted to use that word. We'll hear a little bit about a lot of things that are happening in Maine. You can connect with the presenters after this event to learn more. And we want to hear from you. If you're using technology or are finding new ways to share information across sectors, share it in the chat. If we have time, we'll call on you and ask you to share. The idea of this session is to create an opportunity for shared learning. So again, please don't be shy in sharing your experience. This morning, we're going to start off with a little inspiration. Last year, I'd asked Age-Friendly Socko to present at our technology pre-summit session, but they weren't quite ready for prime time. Today they are, and I am so excited to start today's session with a short video highlighting the innovative, simple, and cost-effective way Age-Friendly Socko is using technology to support older residents living more safely in their community. I'll be right there. See, technology. Gotta love it. All right, here we go.
Age-Friendly Socko is a volunteer community organization serving the city of Socko, a seaside community of almost 20,000 residents located in southern Maine. Our mission is to help our older residents stay in their homes as they age. In 2019, we launched our Tech Handy Helper program. This program was developed to help our residents bridge the digital divide by providing opportunities to obtain smart devices with volunteers to help guide new users through this process. One of the most popular trends to emerge from this program was the use of personal assistive devices like the Echo Dot and Google Home. These devices quickly demonstrated how they can help our older residents stay in their homes more safely, as well as feel less socially isolated. This technology functions as a virtual personal assistant, as it listens to a voice and carries out commands. We know that there are various commercial medical alert systems to help our seniors feel safer in their homes in the event of a fall or an emergency. However, these systems are often difficult for our older residents on fixed incomes to afford. We are going to demonstrate today how for about $40 for a device, $8 for a smart plug, and as well as internet access, we can help our older residents stay in their homes more safely. We're going to demonstrate this by showing you a day in the life of a virtual assistant. Our Tech Handy Helper has come to install the personal assistant device for one of our residents. As you might know, it is not possible to call for 911 assistance through one of these devices. Age-Friendly Socko has worked with our local fire department to have their dispatch number added to our residents' personal assistant devices so that in the event of a fall or an emergency, they can ask their device to call the Saco Fire Department. Our volunteers also add in the personal contacts of each resident, so the personal assistant device will call each contact on the list until someone answers the phone. As we begin our setup for our resident, she requests that NPR be played as her wake-up call every day at 7 a.m. so she can wake up to the morning news. Once she's awake, she'll be reminded about the medication she needs to take that morning. For the midday meal, she asks her device to provide a recipe for a strawberry smoothie and then sets a timer for her daily 20-minute exercise regimen. She asks what the weather is like today as she prepares to go for a walk. When she leaves the house, she has a schedule on her device called Leaving the House that provides certain prompts such as, do you have your keys? Did you lock your door? Later in the day, she prompts her device to add to her grocery list. As evening comes on, she asks her device to turn on the lights and play quiet music. At bedtime, the assistant is asked to read a poem and play quiet music for half an hour and turn off the hall light. These personal assistants make it easier than ever to stay connected and check in with loved ones simply by asking the device to make the call. All in all, these devices can help our older residents stay in their homes more safely while still maintaining their independence and staying socially connected.
Now that's pretty cool, huh? I mean, really, that's just incredible innovation. So we did ask Jean Saunders, who is the chair of Age Friendly Saco, to join us this morning in case any of you had any questions about the video that you just saw. And we're gonna actually, let's see, we're gonna ask Jean to unmute. Oh, good, perfect. You're here, Jean.
I'm here.
Excellent. And I have a question for you. How many folks do you have using this technology in Saco? And do you have any quick stories to share?
Sure. So we applied for a grant and we asked actually to purchase these Echo Dots. And so we had a session at the Parks and Rec, our community center, in which we had a raffle and we gave 10 away. And then we asked them to come back and we helped set them up. It was such a huge success and there was so much demand that we were just recently able to get an additional 25 from our local Rotary Club. So we're going to be doing this process again this next month in October. And people are actually, what we found, because we've had both the tablet program and the Echo Dot, our experience has been that people find it much easier and really like the use of the dot because it's so easy to use and so helpful. So it's been a huge success. So I would say we probably have around right now between 10 and 15 people, but we expect that to go up by at least 20 in the coming months.
That's just fantastic. Well, thank you so much for being here. Any other questions for Jean today? All right. Well, hearing none, I really appreciate you being here. And I'm so excited about this technology. And I know, oh, actually, we've got one question. Is this only for the Saco area? And I'll add to that, which is, would you be able to help other communities replicate this?
Oh, absolutely. Yes, that would be no issue whatsoever. We have our group of handy helpers that are our tech handy helpers that are always very excited to talk about the program. And absolutely, yes, we'd be very happy to help any community that wants to do this. It's very easy. It's kind of so easy. It's wonderful to be able to, to put these devices in and for our older residents, even just to hear a voice, during the day. So yes, absolutely. We'd be willing to help anyone, start this program.
And you serve folks outside of Saco too, right? Some of the surrounding areas, is that right? I can't recall.
Yeah, right now we only serve our citizens of Saco, but we obviously always willing to collaborate. We're supported financially. Gotcha. By the city of Saco, and so we're sort of limited to serving Saco at this point, but we're always willing to help. So please call on us. We're happy to help.
And our last question, which is not surprising, comes from our esteemed researcher, which is SACO collecting any satisfaction data or other data related to the program?
No, but that's a great idea. And maybe we should talk and we can start that process.
I think Mary Luciaffi would be very excited to talk with you about that.
Absolutely.
And one last question, how does the Echo Dot know to keep calling the phone list until someone answers in an emergency, or is that done manually by the person?
No, it's not done manually. It's just automatic. Wow. They go through the contacts until somebody answers the phone.
Wow.
Yeah.
That's brilliant.
Yeah. Well, especially given, the incredible low price and, the ability to be able to call from any room in the house, to call for help is great. It's really wonderful.
Wow. You're amazing. You are amazing. You and your folks in SACO.
You have a great team. Thank you.
You do. Well, thank you so very much for being here to start this day this morning, because it's really very inspirational what you've been able to do in relation to keeping older people safe there in SACO. So, and I know a number of people here this morning are going to be in contact with you.
Oh,
so
great.
Thank
Excellent.
you.
Thank you.
Including our next speaker, by the way,
okay.
Who was excited to hear. So thank you very much. And so next up, we are going to be shifting a little bit from technology itself. We're going to explore how Maine is increasing the capacity to share information on social health needs. So it's my great pleasure to introduce our next speaker, who's Chad McLeod, who's the Director of Product and Communication for Health InfoNet. And just a reminder again, that full bios for our presenters are in the link that you received in your email this morning. So Chad, thank you so very much for joining us today. And I am going to turn things over to you.
All right, awesome. Let me share my screen. And you should see my PowerPoint now.
We can.
All right, super. So let's see. Great. So hi, everyone. As just said, my name is Chad McLeod. I'm Director of Product and Communication at Health InfoNet, which is the state of Maine's statewide health information exchange. This morning, I'm going to be sharing a little bit about how Maine is increasing its efforts to share information on social health needs. But before I get started, just wanted to thank Jess and Maine Council on Aging for having me. It was just 2 years ago that I attended my first Wisdom Summit. And at the event, I felt a little bit like a VIP customer as she and Ted Rooney really welcomed me into the LTSS community, introducing me to all of you and catching me up to speed on your great work. So I also have Ted to thank because, as Jess alluded to, he introduced me to the South Portland age-friendly folks at that very meeting. And just a couple of months later, I became the co-chair of the committee. So it's been really rewarding and informative, both professionally and personally for me. So I'm glad to be here. So
and Ted's here watching, Chad.
So no pressure. All right. So for those unfamiliar with Health InfoNet, I thought I'd just give a quick background on us. We're an independent nonprofit health information services company based right here in New Gloucester, Maine. We launched in 2006 with support from the major health systems to essentially create a comprehensive statewide electronic health record. Knowing that different systems use different EHRs, we connect the dots between them. And we provide those participating providers a system where they can receive a comprehensive electronic medical record on their patients. Since then, we've connected more than 850 healthcare locations across the state, including all acute care hospitals, critical access hospitals, FQHCs, emergency medical service agencies, and a majority of ambulatory behavioral health and long-term care participants. And again, we share our information back to those participating providers through electronic medical records, through real-time event notifications, analytics and reporting, public health reporting, and so on. But in recent years, and which is going to be the focus of today's presentation, Health InfoNet has tried to expand its use cases, data sources, and services to be more encompassing of community perspective. In Maine, there's an evident appetite to set in motion a paradigm shift of how care is delivered by placing greater emphasis on the upstream factors, things that are beyond the clinical definition of care. And that's why we've started to partner with organizations like the Maine Council on Aging, the Maine Primary Care Association, the Maine Health Access Foundation, Maine Medical Association Center for Quality Improvement, and the Maine Department of Health and Human Services, Office of Maine Care Services, and Office of Aging Disability. And these are the types of projects we'll talk about today in greater detail. But first, when I say community perspective, what does that mean? In health information technology, there's a growing movement, which I'm sure many of you are aware of the creation of systems and collaborations that involve cross-sector partners to expand the way the care is delivered to individuals. This effort's a result of increased recognition that the status of an individual's health is more than just the sum of their clinical encounters, that medical care alone can't account for what always makes us sick. And instead, this community-wide focus of the underlying social conditions in which individuals live must also be considered. A common way of describing this, which I referenced earlier, is that there exists a certain amount of upstream factors and characteristics that exhibit further downstream, whereby social, economic, and political circumstances represent those upstream factors, and health risks, conditions, and outcomes represent the downstream factors. I like the graphic on the slide. It came from Robert Wood Johnson Foundation, and what it illustrates is that really 20% of our health outcomes can be attributed to medical care. The other 80% all attributed to those upstream factors like socioeconomic characteristics, physical environment, and health behaviors. And as Jess mentioned, the theme of today's presentations are around how can we move forward with technology despite the limitations that COVID may have brought us. And what this is really demonstrating is that COVID is a really timely example of this reality that we're living in. Factors such as income inequality, community perceptions and cultural beliefs, and access to healthcare services have been identified as some of the greatest influences that are impacting the virus's incidence and health outcomes in vulnerable populations. So this paradigm shift, again, is redefining how the model of care is delivered to bridge the clinical and community divide. In healthcare, we love to use the word social determinants of health to label this very notion. Nowadays, everybody who knows about social determinants of health could likely cite the World Health Organization's definition of it. But you won't hear me or others at Health Infinite use that term. Instead, we like to use social health information or social health data because it doesn't carry some of the same negative or critical connotations surrounding social determinants of health. Because the reality is social health information could be good or bad. It's just the various factors either promoting or undermining the health of certain populations. So we'll use social health information going forward. So that's setting the stage. And to note, nationally, there is a lot happening in this space. It's a very hot topic right now to merge the clinical and the community settings to make a cohesive story of an individual's health. And this slide is really just demonstrating the fact that there are a lot of players in this field. And if you're familiar with the study, you probably recognize one or two, either on the research and advocacy side or data standards, or whether it's the community data platforms themselves. But in Maine, where we're going to focus today, there's equally a lot of good activity, work, and progress happening in the fields. And for the purposes of today's presentation, we're going to look at just 4 of those efforts that Health Infinite has specifically been involved in with various cross-sector partners. So while there's only 4 here, you may know of many more. The first is the Maine Council on Aging's Municipal Data Across Sectors for Healthy Aging Initiative. The second is the Office of Maine Care Services Dual Eligible Special Needs Plan Long-Term Care Data Sharing Requirements. The third is the Maine Primary Care Association's Social Health Data Action Plan for Federally Qualified Health Centers. And the last is the Maine Medical Association Center for Quality Improvement Statewide Community Health Information Exchange Workgroup. And again, what I like about this slide is that it mixes community-based organizations with medical providers, payers with volunteer-led advocacy groups, service coordination agencies with government agencies, and many others. And that just demonstrates the enthusiasm and interest in this area for cross-sector partners, which is the whole point of this in the first place. So the first project that we'll talk about is the Maine Council on Aging's Municipal Data Cross Sectors for Healthy Aging. And because I wear two caps in that committee, which is my role, my day job at Health Infinite, as well as my role as co-chair of Age-Friendly South Portland, I'm going to focus just specifically on the project South Portland pilot, although there are other municipalities happening and underway right now. And this project was an outgrowth of the MCOA's municipal data dashboard convening effort led by Ted Rooney, whereby they brought together municipal leaders across the state to identify various data elements to include in a report that could inform and assess the needs of older adults in any given community in order to drive municipal level data-driven decision-making. And as a first step, as I mentioned, the MCOA worked with the city of South Portland to pilot the creation and implementation of that very dashboard design. In the first year, again, we created the dashboard, we brought together the cross-sector partners, and in the second year, we actually tried to prioritize a specific area in South Portland impacting older adults to implement programs to alleviate that risk or need. And in South Portland, what we chose was falls prevention as our first priority. Essentially, what we identified was that 24% of all EMS calls reported in the city were related to fall-related injuries or incidents. And the majority of those were for older adults greater than 65 years old. And 3 different outcomes are associated with this project as a result of bringing the right partners and the right data points together. The first is that Maine EMS is piloting a mechanism within their electronic medical record system, essentially, which is where somebody has a fall, but is not transported to the hospital, but needs some type of further follow-up to prevent their falls, they can build in a mechanism to refer that individual to a central entity for home visit and assessment for referral of services. That is a proof of concept that's currently underway. The second is that Health Infinite, as the statewide health information exchange, already receives EMS data on every transported or non-transported incident in the state. And so what we can do with that data is to create alerts, which basically say, if a patient has an EMS report generated for them in the system, we can provide a real-time notification to any of their care team members, such as a primary care provider, to alert them that this individual has had an EMS-related incident. And specifically, we're going to try to get even further diving into that data to aware those care teams in the event that there's a fall related with that EMS run. And then the last is Age-Friendly South Portland, as the age-friendly community, is putting together an anchor program, which will be annually, to essentially provide education and awareness of falls prevention and intervention best practices, lessons learned, and various resources from community-based, health-related, and social services agencies in the city. That event is actually planning to be held later this September, assuming all things with COVID continue to go well or get better. So fingers crossed that we can continue the event. The next project is the Dual Eligible Special Needs Plan Long-Term Care Data Sharing Requirements. So lots of terminology that I'll just quickly define with some background information. By January 21st, 2022, all dual eligible special needs plans, which go by DSNP payers, which is a type of Medicare Advantage plan designed to serve dual eligible Medicare and Medicaid beneficiaries, they must ensure that all admission, discharge, and transfer clinical messages for those dual eligible members are sent to Health Infinite. This is meant to increase awareness of care management and care coordination activities among those high-risk individuals. In Maine, the current DSNP payers include WellCare, United Healthcare, Anthem, Humana, and Aetna, which collectively have a network of nearly 100 different long-term care providers in the state that serve those dual eligible members, and which therefore are connected to connect with the Health Information Exchange. Once that data starts flowing, the data is automatically pumped into those patients' longitudinal health records and made available in our systems to other providers in the event that transitions of care or admissions or discharges are made for those patients, and therefore coordination can occur. Additionally, as part of enhancing and improving the care coordination among those dual eligible members, Health Infinite is providing the state's 2 service coordination services, Seniors Plus and Alpha 1, with access to our electronic health record system and notification services. What's important about that is that this really marks one of the first use cases where Health Infinite is providing access to its systems beyond a clinical or provider entity specifically, whereas these agencies provide much broader care coordination efforts. And so while the several decent provider locations were already active participants of the HIE, this project brought in 58 new connections, which means a whole bunch of additional data on high-risk patients that are working with long-term care providers into the statewide HIE. The next project is the Maine Primary Care Association Social Health Action Plan. This was work that came through Maine Primary Care Association's grant from the Health Resources and Services Administration, HRSA, which essentially allowed us to make the FQHCs have various opportunities to expand their infrastructure to support new technological endeavors or interoperability efforts. And what we did was we devised the 2-year strategy with the Maine Primary Care Association. The first is that we continue to connect all remaining federally qualified health centers to the Health Information Exchange. The second was that we worked with those FQHCs to create a learning group that was charged with understanding exactly how they use social health information within their locations. With diverse geographic locales, differing patient demographic profiles, and assorted community-based partnerships, those Maine's FQHCs are uniquely and strategically positioned to shift the paradigm of how care is delivered. They have the cross-sector relationships to promote and refer individuals between medical and community and social and public health related organizations to get the care they need most. And so what resulted as of this 6-month convening effort was a set of technical recommendations which we addressed to Maine's FQHCs in order to enhance and support their data collection, exchange, and operationalization of social health information. We learned how are they collecting the data, through what social risk screening tool, how are they standardizing that data into common definitions that a Meals on Wheels or another type of food bank or housing organization could make sense of that weren't strictly in clinical terms. And then we understood how they get those information out of their system to be usable by other organizations. And that report will be made available to the public in the end of this month for a deeper read. So with each of these 3 projects, what have we learned? And what I was thinking of was that they could be bucketed into 5 categories. The first is around community engagement and consensus. We've learned that bringing the right people to the table who are providing critical care services to individuals is incredibly important. Whether it's community-based organizations or medical providers or health plans, everyone who has a say in an individual's health is important to bring to the table to break down historical barriers for the benefit of patient care, safety, and quality. Next, we learned a great deal about the longitudinal health record. If we were able to collect information on a person's health, well-being, and welfare, what type of information would we need to bring together to tell that story? For the Maine Council on Aging's project, it was that Maine EMS data is critical to working with falls prevention. With the Maine Primary Care Association, it's that collecting screening and diagnosis information from social risk screening assessment tools is also really important. And then as part of the Maine Primary Care Association's project, we learned a lot about how to technically operationalize the data inputs and standardize them into definitions that, again, could work across sectors. At the same time, we determined the need for precise data infrastructure to connect all the dots. That is, our data submitting entities. Akin to how the HIE connects disparate, non-corporately aligned EHRs, we have to do the same with community-based organizations. Key to this is knowing that these community-based organizations are not using the same type of EHRs as medical providers are. Sometimes they're using Excel spreadsheets, and we have to be able to work at that level of technology to make it work. We have to be able to bring that information just as we would with the EHR. And lastly, we learned a great deal that if we can connect these dots and build a data set that tells a story of an individual's health, then we can greatly facilitate and encourage a paradigm shift of how that care is delivered. Which leads us into the last project to mention as part of this presentation. And before getting into the project is all about building a community health information exchange. It's bringing all of that data, those partners together, and putting it within a platform that is easily accessible by all to be able to view a patient's information within an easily accessible format. And when you look at the pyramid that nationally folks look at to build that community health information exchange platform, well, a lot of the pieces are things we've already understood through those other projects that may seem disparate on the surface, but actually are quite unified and cohesive. And so if we look once more at this chart, really there are only 3 left areas that we haven't really truly touched on in great detail that need a closer attention. Those are related to data governance and person consent. How can we make sure that this platform is secure and private, that the appropriate data authorization, provenance, and ownership principles are in place? And most importantly, that the patient's voice is heard so that stigma concerns are mitigated. Then there's the shared health record. Once we put all the dots together, how do we get it out to the right people? And then what else can we put on top of that shared health record, whether it's a universal social risk screening tool for different centers that don't have Prepare, a resource database like 211 that's embedded within the system so that providers always know the closest food bank nearby, or a closed loop referral management function so that you can actually interact with that food bank to make the patient a new client. It could be event-based clinical and community notifications. Perhaps it's population level analyses and structural and social determinants. It could be a number of things. And there are a number of efforts across the country, such as in San Diego and St. Louis, that are front runners in this space that provide a really great example for us in Maine to follow. And so that's the project that is being led by the Maine Medical Association Center for Quality Improvement and MEHAF as a way of trying to bring those dots together to figure out how we move forward with a shared vision in the state of Maine to build this community health information exchange work group. So running short on time, I'm going to conclude with 2 quick slides. The first is, well, we're here for Maine Council on Aging. So why do these efforts make sense for Maine's older adults? And I tried to tell a story with the slide. As we age, we require greater and different types of services to improve our health, wellness, and well-being. Medical care alone, as I mentioned previously, cannot do everything for us as we age. We need access to food services. We need the right housing. We need transportation to the grocery store and to our medication and into the pharmacies to get our medications. Those are types of services that are all related to our health as we age. And Jess has mentioned these statistics before, but by 2030, over 70 million Americans will be over the age of 65. That's 2 times the number as it was in 2000. And in Maine, what's interesting is that 24,000 adults are aging 65 years or older per year. There are 75,000 adults that are over the age of 65 who need care but won't qualify for it. 10,000 adults that are waiting for housing, and 65 hours of approved care that won't happen because of the lack of workers. And compounded by this is that we found that 90% of adults over the age of 65 say they want to stay in their homes as they age. That is compounded when we think of systems that don't exist today to support these needs, technological systems that don't support their needs. And so to adjust to Maine's aging landscape, we have to think smarter, not harder. We have to build platforms that can proactively forecast, prepare, and proactively respond to these risks and these needs. And that's essentially what the Community Health Information Exchange is designed to do. It's to make a transparent platform where a person's health can be conveyed once and make it very clear to others participating in their care. So the last thing that I'll touch on here is a use case. And I think this really brings everything together for folks. And so let me just change my screen here. There we go. So an older adult is gaining weight, they're experiencing anxiety, and they have unusually high blood pressure reading at their most recent primary care visit. They've also recently lost their driver's license, which was their primary means of transportation. So thinking of what a community health information exchange could do for this older adult, well, it starts with the primary care provider using the universal social risk screening assessment within the platform to identify the individual's social health risks, which identifies the individual as food insecure. With this information, the primary care provider could use a centralized resource directory like the 211 database to refer the patient to a local area agency on aging, which also serves as the community's Meals on Wheels service. Now, the patient and the Meals on Wheels are connected to help mitigate the food insecurity issue, but adding one more layer to this is that the area agency on aging can then can sign up for real-time alerts of admissions and discharges to hospital settings in the event that the high-risk individual goes in and out of inpatient or emergency department settings over time. That way, the Area Agency on Aging can prevent food waste when they're notified that the individual is admitted to the emergency room, for example, but then also resume their services once they know that they've been discharged to make the most efficient and effective use of their service. So scrolling through the others that we may not have time for today, I'll end briefly with just summarizing the slides that we talked about, and to say that there is a lot happening in the state of Maine that may not be connected necessarily project by project, but when you look at it on a big picture, they're all talking about the same thing. They're all trying to tell a story of an individual's health, wellness, and well-being through bringing together the right cross-sector partners and with the right data sets to put a transparent platform in place. So I hope this was informative, and if there are any questions, I'll look at the chat now, but Jess, I'll send it back to you.
Well, thank you so much, Chad. And now is a good time to say that Chad's screens, which are fantastic, PowerPoint, and all of the presentations today will be available later, and we'll send you the link to those PowerPoints. I don't see any immediate questions, Chad, in the chat, but if they come along, hopefully you could chat a response. Thank you. So we are going to now move on to our first panel presentation, which is a panel on advances in using technology to meet social health needs. As Chad just mentioned, about 50% of health outcomes depend on socioeconomic factors and physical environment. So addressing the social health needs of older people is critical to maintaining health. During COVID, this became difficult to do, obviously, in person. So this next panel will explore how they're responding to the social health needs of older people using technology. So it's my great pleasure, and I'm just going to introduce them all at first, all at once, and then we'll call on them as their turn comes up, is Ellen Friedman, who is the Program Manager for Community Health Improvement at Maine Health. Kristen Overton, who's the Chief Strategy Officer for Healthy Living for Me. Maya Dyke, who's the Contact and Business Manager for Healthy Living for Me, and Melinda, otherwise known as Mel Levering, who is the Manager of Virtual Health at Scoggin Home Health and Hospice. So first, we will hear from Ellen. So let's take it away, Ellen.
Okay, I'm going to share my screen if that works, if Chaz is no longer shared. Okay, let's see. Just need to fix this, right?
It says it's started.
Okay, do you see that? You probably see all of it. I can't get rid of some of this.
We
Okay.
don't see any quite yet.
Oh,
So there you go. Now we do.
okay. All right, and you might see it on the side too, so can't seem to get rid of that with all the other panels in the way here. Hang on. No, did I get rid of you? Oh my goodness. Okay.
No, you're fine. There you are. We see you perfectly, and you're in presentation mode. You're doing wonderfully.
Yeah, there's a bit of a
your shirt kind of matches your presentation. So
really?
That's really
okay.
Nice.
I was wearing black earlier, and I thought like I had a dark background, so I needed something brighter. So hi everyone. There is a little bit of a delay, so I think that's what's happening with the. Of course, this is the Zoom world. So I am thrilled to be here. You know, when you're on Jess's radar, you just, you say yes. So really happy to be part of this. I work at Maine Health in the Center for Health Improvement. I work on the Community Health Needs Assessment and the Community Health Improvement Planning for the 9 Maine Health hospitals. Work very closely with the Healthy Aging Program with Peggy Haynes and all of the staff there. So this is an issue that healthy aging is really a priority area within the Community Health Needs Assessment. And also over the past 3 years, social determinants of health has also become a significant priority. So combining those things today to talk to all of you, and a tool we're using called Aunt Bertha, which great going after Chad's presentation, which was, sort of the really large platform. And I'm just really going to explain sort of how we're using one specific platform within Maine Health and within all of Maine to support social needs for the community and for patients. So I do think Chad said build the platform. So that's what we're doing. And also wanted to wish folks a happy new year today who are celebrating. Okay, so I'm going to jump right in, and we'll probably add a lot as I go along here, but folks may already know about Aunt Bertha, but just to give you a little background, this is one of the social needs platforms that is out there on the market. It's sort of, out of the box. You can purchase this with a fairly, not a lot of money to purchase a contract with Aunt Bertha. And the reason we started with this platform at Maine Health is because it's Epic integrated. And this allowed our providers to connect people to resources. And it also allowed our providers, it encouraged providers to actually ask questions and get into some of the social needs because they had these connections available to them. So basically, Aunt Bertha is a directory of free and reduced cost social services. And it's powered by a data team in Austin, Texas. There are about 52 folks working on this project to sort of populate the data as we're asking the data to be populated. So we don't add to the database, we send it to them, they vet the resource, and then they upload the information in about 2 days. So we are not responsible for always going in and checking all the details. We can just send them a message and that data can be updated or added. They also review it every 6 months, make sure it's up to date, and change any phone numbers or hours or anything like that if it's not up to date. So it is community resources for medical care, food, housing, social needs. I mean, we do refer to this as social needs, not necessarily dealing with all the social determinants, because the difference being that these are things that these are really actions that people can take to sort of address some of their social needs, not always getting to the social determinants, which are sort of some of the underlying factors. But we, are sort of chipping away at that. But this is really a social needs platform. And then we are also able through this platform to communicate with providers, with community-based organizations, and refer to these organizations and it's a bi-directional referral. So you will know if the information has been received and if the patient or the individual has gone to pick up the diapers or has gone to the food bank. And the reason we know this is because organizations that choose to be part of this network, not just that they're on the platform, because anybody can be on the platform, but if they choose to receive referrals or have communication with those who may be sending patient information, they claim their organization. And when they claim their organization, they are then sort of part of the network in the sense that they can receive these referrals and also receive any data on the activity, how many people were referred within the month, what was the age breakdown of folks that were referred, what were the needs that people were looking for. So they will get all of that data every single month from the platform. And it is available, as I said, it's 24/7. It's more of a self-help way or self-directed way. And there isn't a person that answers the phone, so people have to have some skills to navigate this, or working with care managers, working with patient navigators, working with community health workers, working with town managers, working with legislative aides to assist customers, clients, patients with finding the resources if the individual themselves is not as comfortable using this. And also, I had mentioned it's part of the Epic system at Maine Health, so it's integrated into the Epic record. Patients have to provide consent to have referrals made. It's all HIPAA protected. And we have a new opportunity through the MyChart space where social determinants of health screening is loaded on MyChart now. Patients can do some of these screening tools before their visits and can make can identify things that they need and go on to Aunt Bertha right there and find the needs, or when they come into the doctor's office, medical office, those screening has already been done, and the provider can follow up with those referrals, which is really awesome, because now the annual wellness visit, the screening tools for are on my chart, and that's really been a big push with the Healthy Aging group to get those assessments done ahead of time, so that when the patients come in, they have that conversation. Mentioning how Maine Health is using Aunt Bertha, so it's to address social needs through both provider and patient community experiences. So they're on the Aunt Bertha platform. There's a staff site, which is the Epic integrated site, and has a provider sign on us, or a staff sign. You need to use your credentials to sign on to that. And there's a public facing site, exactly the same site. It's just not Epic integrated, and the community can go on there and navigate, make referrals as needed for that, for themselves, or for a family member, or for someone in their community. We are largely using it as a care management tool, and this is, as I mentioned, through Epic and MyChart. It's also enabling us to really foster and leverage relationships with community-based organizations that address social determinants of health and social needs. And we everyone was I was aware of a lot of these organizations, but it wasn't really under one roof. You might have been able to find it on a list. A lot of providers or social workers had notebooks full of information, or you could search different websites. You can still go on 2-on-1 to find this information. This is a way that the practices, the groups can curate and sort of tailor their own needs. So if you're a substance abuse grant, which is what we've been working with a lot of the community, the local health systems who've had grants around substance use, you can go in and say, what kind of resources do we have for people locally to support the efforts we're doing around whether it's IMAT services, do we have the recovery services do we need? Do people know where to go for peer support? Do people know where to go that they have naloxone distribution? So those kinds of relationships are fostered to really support the work that both the local health systems are doing, what the practices are looking for people's needs based on these screening tools, and also what the community is really providing and wants to really link people to those resources. The community engagement aspect is we have a work group from few people from every local health system. So there's 9 hospitals, as I mentioned, within the Maine Health footprint. And then beyond that, we are working with folks that are focusing on more topic areas like the healthy aging community or the behavioral health space as part of this community engagement work group. So everything is really hyper local and very tailored to needs. And that's really the only way to sort of build this platform, is to get that kind of input. Because if you really just sort of look at what it is on the surface, you're not really going to get the actual services that folks need and are using. It also helps us to identify gaps in resources, because getting a monthly report on what people are looking for, give you an example, looking for dental care always shows up in the top 2 or 3 or 4 needs that people are searching on this platform for. And as we know, that's a challenging resource in the state of Maine. We had Mainly Teeth step in and say, we know that people are looking for this service, and we want to use this platform to help us connect with patients and with the community. So they actually use this completely independently of Maine Health. They don't need to be part of Maine Health to use this. They are a claimed organization, so providers can send resources to them, but they also use it for themselves to manage and track all referrals for all of their services. And I'll show you a little bit of the stats related to that. And finally, an example that I put in here is using is collaborating with State, New England, and 2-on-1 to really support a lot of these efforts. So some of the efforts that Chad was talking about with the CIE, we're part of the New England Aunt Bertha Network. It's a collaborative with all the New England states, and really working now to collaborate with Maine 211 so that the resources are all shared. They're at the back end, all the resources are shared. There's different ways of entering the system, but when we add something to the Bertha platform, it would automatically be added to the 211 platform. So that's sort of how the back technology would work to support that effort. So we're in conversations to see about making that happen. As I mentioned, social determinants is a priority area for Maine Health. Largely, this came from the Community Health Needs Assessment. And for the first time 3 years ago, we're getting in the process of doing this again now, social determinants of health was identified as a priority area. So we typically, and these things don't change, people know this, tobacco, cancer, substance use, obesity, these are really our key priority areas that we've been focusing on through the health needs assessment and the improvement plans. And social determinants always flowed through all of these areas, but now just put a finer point on it by calling it social determinants out as its own unique priority area, as well as being included in a lot of the other priorities. So the issues here, access, ACEs, which sometimes is included in mental health and sometimes is included into social determinants of health, depending on the local health system, looking at employment, income, which also includes poverty, food insecurity, housing, social isolation, and transportation needs have all been identified as social determinants of health for local health systems and what strategies they're looking at to address these needs. And we know that these needs have major health impact and that reducing the barriers to these will lead to better health outcomes. I wanted to quote this source is a Siren network out of UCSF, and they've done a lot of research on integrated social needs platforms, networks, and some of their research has shown, and others has shown, that individuals with unmet social needs are more likely to have difficulty managing chronic health conditions. Individuals with unmet social needs have multiple needs. So we want someone to come in potentially who might have one need and find it's not just food insecurity, it's childcare, it's housing. There are multiple things, and they can navigate all of that on this platform, and a provider can make referrals to all of that on this platform. And also under provider experience, what we've learned is that I'd said before, in order to encourage providers to ask these questions, we need to have what can they do about it, and what's their next step? How can they address some of these needs rather than just leaving that open-ended with the patient experience? So they're able to follow through with providing these referrals, and rather than just handing folks a piece of paper or a list, they can actually make those referrals. And this has contributed to lower burnout because there's a greater capacity to meet patients' social needs, and also the trust and the patient-provider relationship is enhanced through this type of interaction. So the EPIC teams for care management are able to log on. As I mentioned, there's a browser single sign-on just for staff, and then patients and anyone else can access through this link here. If we have time, I can show you that at the end, but you'll get these slides, so you're able to connect to this link. And this is just a screensaver that's on desktops of providers to remind them that these resources are available. And if patients do need more hand-holding, we have something called the patient assistance line that can actually help patients navigate with more of a phone call and more follow-up than going on the platform on their own. So this is sort of what the interface looks like on the platform, and you'd enter by zip code. This is the Maine Health platform because we've curated this site, but there's certainly an out-of-the-box one. If you went to findhelp.org in any state, you would find resources for this. Used to be called On Bertha, now it's changed to Find Help. But we kept on Bertha. We just loved it so much. We kept on Bertha because everyone started to understand what On Bertha was. So we thought, all right, it's unusual enough. We'll stick with that. So the Maine Health site is called On Bertha, but it is, as I said, open to anybody, anywhere to access this publicly. It does not have to be a Maine Health affiliation at all. And anyone also can go down at the bottom of the site where it says suggest a program. If you don't find your program on here, you can add your program. And this team in Austin, as I mentioned, in 2 days will upload your program. And then if you wish, you can claim your program, which means you will want to receive these referrals. And there may be a little bit more information that you provide because you want to tailor your listing to meet your needs and your requirements. You want to make sure you have the right phone number and the hours and the ease at which you want, or how you want people to reach you. So this suggest a program is on every single page. And when we started, we've added thousands of programs to the platform, and I'll show you sort of a little bit more about that. So we put the zip code in here, and this isn't a live link, so I'll just explain that, and then it would take you to that local area. So here's an example. And we've come here for housing, and we've found a couple of the resources for housing. We've identified the zip code, which I have a very small screen here, so I'm trying to, and we'll see these are the listings that have come up. If you want something closer or further away, you can navigate on the distance up on the right corner. It gives you the distance from which the service is. And if it doesn't exist except for 50 miles away, if you're up in Norway, it's going to say, the closest is 50 miles away. So we can't make these referrals, these show up if they don't exist, but that is another one of the advantages to being able to see what people are looking for and identify where these gaps are. So you use the search to look for the program or the type of program you're looking for. And then if you want to further filter that, you can through this filter in the middle. If you want to just look at it for over 65, those are the services you want for housing, veterans, then you can filter it. If you're just looking for children, you can filter it, or for a particular region. So when you may get a lot of referrals, just in a general, this is a region because it's a zip code, but if you wanted to narrow it down more, you could use that filter feature. Okay. I'm trying to think if there's anything else here to show you. So each one of these things is a program card. And as I'd mentioned, once you claimed your program, on the right-hand corner, it says work here, claim. That would be a big check mark if that program was claimed. And the information here, there may be an intake form. If the health, potentially if a CAP agency has a health intake form that they want people to fill out ahead of time to see if they, or an eligibility form or something to qualify, it can be posted right on here. If it's a course that someone's signing up for, they can you can integrate Course Storm and other sorts of things so people can sign up for the course right here. It depends what the service wants the public potentially to be able to do when they come on to when they find their card. If they just want them to call, that's fine too, or go to the website, that's fine too.
Hey, Ellen, we've only got just about another minute.
Okay, so this shows you the types of services that people are looking for. That we get this snapshot every month, and this, 20% are looking for housing, and 18%, I can't read that, are looking for food. And this gives us a list of who's looking for, or what is being searched for. This, for example, this is in July. This gives us an idea of the most engaged programs. So I'd mentioned mainly teeth. They have, close to 2,000 interactions, people looking for their service because they are really pushing this out. It's on their website. It's how they're interacting, getting people into dental care using this platform. So this is a month. This is May through July, and these are the top programs. Some of them are claimed, and some of them aren't. You don't have to be a claimed program, but that does allow you to receive the referrals. The diaper bank has always been a huge asset to the program too. At one point, there were about 60 a month referrals to the diaper bank. We get the zip codes of where people are searching from, and we can see what activity is happening in what zip codes. And then we can see the number of programs that are claimed and being added each month. Some of them are local, some of them are national, and some of them are state. And we do have an Aunt Bertha she's a customer representative, and she's servicing all of New England. So she's doing this with our community engagement group. So we have a smart sheet of what programs are in the area that are on the platform and not claimed. And if people have relationships with these programs, they reach out and they can get them more interested, and we can provide training. Our customer rep provides training to any local groups. So this is just sort of what we put out to local groups. Join the network. This could be a one-on-one training. This could be, you could get your coalition together to be trained, a group of food service providers to be trained. So whatever the group you're working with is, we can provide the training so they understand how to use the network, how to get the most out of it. And, you know, I think yeah, actually that was kind of like, good to see, look at how well that was timed. You know, I think that there are some things that came up from Chad's presentation to say that, you know, this Aunt Bertha platform can be part of a larger information exchange. In fact, Aunt Bertha works with San Diego, works with other states, and works with to create sort of these partnerships. And their philosophy is really, there's no wrong door. You get into this system through Aunt Bertha, but that's just one doorway. There's lots of opportunities to figure out how these partnerships can be put together, these collaborations that do take some time. And I know people are very interested in improving health outcomes. Why else would we be doing this? So as we get more traction and more evidence and more information of how we're linking people to the services, then it's seeing how people's outcomes improve. That's something we're very interested in doing. So, for example, we started the National Diabetes. Yep.
So sorry. We're going to have to move on to the next presenters. We're almost out of time for this panel. So,
okay. I'm going to stop share. Hang on a second.
Yeah, that's good. That's good. One of the presenters has to sign off early. So I just wanted to thank you so much for your presentation. There was one question in the chat and I've already responded, but if you have other information about who else is using Aunt Bertha in Maine, that would be great. And if other folks have questions specifically for Ellen, put them in the chat and she will respond. And next we're going to move to Maya Dyke and she's going to talk a little bit about what's happening with Healthy Living for Me. Are you there, Maya?
Yes, I am. Thank you so much, Jess, and thank you, Ellen and Chad, for your presentations as well. As Jess mentioned earlier, my name is Maya Dyke, and I am with Healthy Living for Me. I'm our contract and business manager here. For the sake of time, I will touch on both of the pieces we're talking about this morning, both how Healthy Living for Me is using technology to support information sharing, and also how technology over the past year and a half, really since the pandemic started, has supported our programs and those of our participants. So to start, just a quick recap of what we are in case there are some new folks on the line. Healthy Living for Me is the statewide community integrated health network here in Maine. We are made up of a joint venture partnership between Spectrum Generations, Seniors Plus, and a Rustic Area Agency on Aging. So our executive team are our managing partners of Healthy Living for Me. And what it means to be the Community Integrated Health Network, also known as SIGN. It's kind of a hot word right now, or title, I guess you could say. What it means is that we bring together many community-based organizations and provide who all provide, similar services under one contracting source. So the Community Integrated Health Network is that one singular contracting source, which in turn makes it easier for working with funders and for Mainers as well, and that of our partners. The Healthy Living for Me database is currently our main coordination tool that we use. And the data base that I'm referring to is our Healthy Living for Me website, very similar in terms of what Ellen was just referring to. This brings providers to one place for a cohesive access point, shared listing, singular source for participants, leaders, and also our providers. So when we say leaders, or when I say leaders, that's just really the people leading our programs, whether they're the evidence-based programs or health and wellness programs. It allows them one point of contact. Our website does have a front end and a back end. For the sake of time, I won't go into a lot of detail, but it allows us to capture referrals, self-referrals or referrals from other providers, other community-based organizations for statewide network workshops that are scheduled. It allows us to also do the same for registration. So people can self-register, someone can register someone else with their permission, collect data. So data across the state of all workshops being offered across programs, and even more. Our site has capacity for payment and all kinds of other pieces. Currently, Healthy Living for Me operates primarily out of grants through the Administration of Community Living. So most of our programs are free, which is great. We strive to keep them that way, or provided to our participants at low cost. When we say participants, those are people just actively participating in our programs. So June of 2021, so this
we've hit a frozen person. Maya, are you with us?
Can you guys hear me now?
Yeah, yes, you might try turning off your video so that you can come through a little bit clearer.
Yeah, I'm so sorry. So where did I leave off?
Well, you're still frozen, so I'd suggest turning off your video, and I don't remember the last thing you said, I have to admit.
Was the date.
The date. Did we lose her entirely? Oh, technology, that's funny. Not really. Yes, June 2021. Back but muted. So you're still muted.
All right. I do apologize for that. Thank you, Krista. I will stay off video. It appears that our internet is unstable, so I do apologize. Thank you for confirming the date. So as Jess just said, it was June of 2021 that marked our 3-year anniversary of the Healthy Living for Me website. So now, so that we can provide more time for our last panelist to speak on what they're doing as well, I want to touch on how our virtual program has really transformed our ability to reach many Mainers, supporting, their healthy aging, whether it's in, wherever their choice of kind of living is at this point, to support that, and how our iPad loaning program has helped us reach those Mainers that do not have internet, do not have devices or that connection to participate. So due to the pandemic, we really pivoted, like many organizations, to change how we were delivering programs. So through the approval of our different evidence-based programs, we were able to offer these online. Virtually. And what virtual means to us is that it can be either through Zoom. Some of our community providers, our partners, use other platforms that have been approved as well. The one that we have primarily being used, is Zoom. So what it means is it's either online or telephonically, any kind of virtual means of reaching people. That includes, all of our programs at this point to some capacity. Now that falls prevention programs, our caregiver programs, and chronic disease programs are online, just our evidence-based programs. Since April of 2020, let me get these dates correct. So since April of 2020 through August of 2021, we have offered 125 workshops successfully online. I think that's, speaks a lot to how we've been able to band together this group of community providers and start to offer programs in this way to reach people still in need, even though we were physically apart. How this has really affected Mainers is, and us as a network, it's allowed us to reach more people. At the beginning of the pandemic, it was kind of this echo that we kind of all of a sudden were able to really pinpoint, was that we did have a factor that we like to call the small town Babel factor. So the small town Babel factor took place when we were only leading in-person workshops and only had the means to do that. We had people saying, I don't have interest in going to an in-person program because I know all my neighbors. My town is made up of X people. I don't need them knowing the chronic conditions that I'm managing. This is just one example of, how we've been able to break that barrier. Now we have people joining online programs. They may be in a Roostic, joining people in Southern Maine. And what's really nice is that you have that anonymous, very confidential ability, feel and ability to share freely on a virtual workshop like that. So really, putting it very simply, technology has supported healthy living for me and our providers to grow over the past year plus. The tablet loaning program is just one other means to allowing Mainers to have access to our programs. We do have a pool of iPads that participants can borrow to participate in workshops, and we provide them with the information they need to be able to use those successfully. So that kind of training and support as well. So for the sake of time, I'm happy to answer any questions. Feel free to shoot them in the chat box. I didn't prepare any formal slides for the panel today. So I'll also put my contact information in the chat, and I'll pass it back off to Jess. Thank you, Jess.
Thank you, Maya, so very much. And it's really exciting to hear that little piece about how people are responding. And we've heard it before, that they don't like to go to classes if they live in congregate housing, affordable housing. They don't want to take a class downstairs because their neighbors can see them. So it's really interesting to see the technology has sort of solved for that challenge. So thanks for mentioning that.
Yeah. I mean, of course, there's other challenges that come with technology, but some kind of high level and positive notes that I wanted to touch on today, certainly.
Thank you. Again. Well, so next we're going to be hearing from Mel Lovering, who's the manager of virtual health at Scoggin Home Healthcare and Hospice. Take it away, Mel.
There we go. Now I'm unmuted. Good morning, everyone. Hopefully you can hear me okay. I want to thank Jess for inviting me to participate on the panel again this year. And also just great hearing from the other speakers. I love hearing what else is happening around the state of Maine. It's easy for all of us to get in our own little bubbles of what we're doing. So very exciting things happening. I am, as Jess said, I'm the manager of Scoggin Home Healthcare and Hospice. I'm located in the Lewiston office, but we do have 6 different locations. I'm going to share my screen here real quick, and hopefully this will come across.
We see it.
Yep, great. I'm just going to do this. Okay, so a little bit about Scoggin for those who might not know. We are Maine's largest independent home health care and hospice organization in the state. We serve over 185 communities in Maine, many of them rural. And so we have home health care services, palliative care, hospice, and my group is telehealth and remote patient monitoring. We have been doing remote monitoring in the home for our patients for over 20 years. I've been with Andrew Scoggin for just over a year, but they have, and even again, considering what we've all been through with COVID-19, where I think a lot more people are hearing about technology in the home to take care of patients. Andrew Scoggin was doing this work long before. So I think that's important to know, is that really, even though we've been doing this a long time, I think a lot of the uses that we have found, or ways that we can work with our patients outside of medical needs, that's really where we have learned a lot over this past year with the pandemic. For those of you who aren't familiar with remote patient monitoring, the word telehealth is very broad. It can be applied to so many things. Of those virtual visits a lot of people were doing during the pandemic with your doctor because you couldn't go. Your practices were all shut down, and at the height of the pandemic, we couldn't go anywhere. So remote patient monitoring is a little bit different because it is collecting medical or health data. A lot of times it will be taking blood pressures or oxygen levels, weight, health analytics that can be transmitted automatically to a care team so that they can kind of keep a close eye, especially on folks that may be coming home from the hospital and being very vulnerable. So this slide just really illustrates the process of what remote patient monitoring does. And again, it really does have that real-time connectivity of giving a snapshot of what's happening at home when a patient leaves the hospital or is managing a chronic condition. The technology that we use is in the bottom corner there. We have a partner that we use called Health Recovery Solutions. The equipment, like, again, I mentioned, if we are managing a weight, a blood pressure, you would have Bluetooth devices that would essentially work with that tablet that you see. It's a 10-inch screen that is kind of like an iPad. It's push button technology. Again, this connects in the home and it transmits data daily to our telehealth nurses here in the office that will keep an eye on things. But within that platform too, I think, again, is really the communication piece. We can do a video visit. We can communicate through text with the patient. And we'll talk a little bit more later about some other things that we're using it for in terms of social isolation, which we all know has been a real issue for folks over the past year and a half. There is also education available in there, things that can engage with the patients when they're at home to learn more about their disease state or different topics that might be of interest to them. This just is a slide illustrating our care team that we use. We do have a nurse practitioner for medical oversight of our remote patient monitoring program. We have 3 telehealth nurses that communicate with patients every day, and we'll make a call to them if they have concerns about what they're seeing through the tablets. And this team works, again, clinically, but also we find that our nurses get into a lot of social conversations with the patients who will indicate other things that are going on with them outside of their medical needs, or things that might be contributing to their medical needs. But we hear a lot about someone who's lost a spouse, someone who has kind of fallen into a depression because maybe they're going through a rough patch with their condition. They might have lost a pet. So these are the things that we kind of learn about. And as well, through the tablet, we have surveys that come up that patients, especially when they're first getting that monitor, will ask social determinant questions. Are they having, are all their needs, their basic daily needs, being met? A lot of times when patients do come out of the hospital, they're very overwhelmed. They have a home health nurse coming out. They're getting asked a lot of questions. They've been given all this stuff from the hospital. We have to be very careful about how many additional questions we ask them through these tablets. So we do try to keep it general to that topic of just understanding if their basic daily needs are being met for food and shelter, safety, And also we ask them if they would like to interact with any of our volunteers. So what we have done over the last year is we created a program using our volunteers here from Scoggin, thinking about the way they've been impacted by the pandemic, as they haven't been able to go out and see patients and be in the homes. So we've decided to use our technology where our volunteers can schedule video visits with their patients. And we identify them through the tablets of asking them if they would like this program, or perhaps one of our nurses will think they're a good candidate and ask them if they would like to have a volunteer connect with them to really talk about whatever is on their mind. And we have trained 15 volunteers to use an iPad from their home. They're matched with the patients based on the needs of the patient and what they want, who they want to speak with and what they want to talk about. A lot of our volunteers are also trained in hospice, so they've had a lot of good education on the types of things that can come up, some very serious conversations, and also where else they might need to refer patients to based on those conversations. So we are still, finding different ways of reaching. We have only a handful of patients right now that are using the program, but we also try to have that survey. A lot of times, again, when someone first comes out of the hospital, they don't want to think about having more services. That survey question will come up on the tablet if they're still on service 60 days later, and ask them again. And sometimes by then they're ready to kind of branch out and look at other things. So we're really excited about where this program is going to go over time and how that's going to impact patient experience for us. And lastly, just outside of the conversation, we just get asked this question a lot about sustainability of our program, because it is, I think a lot of people have referenced a lot of grants. It costs money to implement anything that we're doing, and nothing is free. A lot of people want to know how sustainable this is. But in terms of the remote patient monitoring for our program, it is reimbursed by Medicare Advantage plans, and Maine Care will pay for the monitoring services if someone is on home health. So there are some methods to recoup some of our costs, but it's certainly not perfect, but it's a start. So that's all I had to share with the group. And again, I'm happy to take any questions or.
Thanks, Mel, so much. And we are running a little bit behind, but there is one question, and I know we've got some other folks who are also going to talk to this. So I think just a global answer would be useful. Is remote patient monitoring only available for patients open to your home health? And I know the answer is no, it's available generally, but could you just give an overview of how people are entitled to get remote patient monitoring? Oh, you're muted. Hang on for a second.
There we go. I have to get permission from you first. Yeah. No, I think that's a great question, and I should have mentioned that. It is absolutely remote patient monitoring can be offered. In fact, we're really branching out on that now because a lot of patients coming out, they don't always qualify for home health. So we're finding that using remote patient monitoring is another way for us to get that patient connected so that we can keep an eye on that chronic disease. Also, as part of our palliative program, that's another big area where we'll use remote patient monitoring. And then what we find is people kind of come on and off services. They might not qualify now for home health, but something happens and then they go on it, but at least they have that monitor in and they have some support when they feel vulnerable. And the other piece is a lot of times if they're coming off of home health and they've had a monitor, they'll ask us to keep it, and and maybe they've had a medication change or their blood pressure is kind of unpredictable, and we will work with their primary care practice to continue on the monitoring and to bill their insurance if it's appropriate.
That's terrific. Thanks so much, Mel.
Mhm.
So if there are other questions for any of our panelists this morning, please feel free to put them right into the chat. Our folks will be around. I know Mel's only around for a few more minutes, but we will be sharing contact information. And so we are going to head off to a break right now. And what I will say is to catch up, take care of your needs, fill your coffee cup, let your dog out, let your dog in, pet your cat if you have a cat. But also during this break, we will also have a moment of movement and mindfulness. We are inviting our guests who are spending an awful lot of time on Zoom. Me, I spend 12 hours a day on Zoom a lot of times, or at least in front of my computer. And so last year we found offering some wellness breaks with some actual ideas about how those of us who are stuck to our computers all day can add a little mindfulness and movement to our days. So we've invited Anna Guest, who is the Age Well Program Specialist at Southern Maine Agency on Aging, to join us this morning to share a little bit of information around mindfulness and movement that you can do. And this wellness break is sponsored by Aging Me, the Geriatric Workforce Enhancement Program in Maine. So I'm going to turn things over now to Anna.
Good morning, everyone. Thanks so much for having me and for inviting me to be part of this wellness break. It's a pleasure. So I was thinking about technology, and like Jess, I find that I am spending many hours glued to my computer screen these days. And so one of my wellness tips that I thought we'd kick it off with is just a break for our eyes. So I'm also going to welcome you. If you want to keep your camera on for this, great. If you are more comfortable turning it off, that's fine as well. But to start with our eye relaxation, let's just rub our hands together just briskly. That's going to create some warmth. And then just place them over your eyes. So close your eyes and just let your eyeballs basically relax into the dark and the warmth of your palms. And while we're here, we're going to do some just gentle eye movements. So gently looking up towards the ceiling behind your closed eyes, and then down towards the floor, and up and down, just gentle movements, no need to strain or stress here. And then moving the eyes over towards the left and the right, left and right. And then we're going to sort of do a circular motion. So we'll start up to the right, down and to the left. Once more, up, right, down, and left. And then we're going to switch the direction. So we'll go back up to the left, down, and to the right, up, left, down, and right. And then just give your eyes a moment to relax here. Great time for a deep breath as well. And then just gently let your hands float away from your face. When you feel ready, blink open your eyes. And then another really important eye tip here is just throughout your day to take time alternating your gaze sort of between something close up and then something far away. And that is very helpful in just letting your eye muscles relax. So you can use the 10-10-10 rule or the 20-20-20 rule, which is every 20 minutes to look up for 20 seconds at something distant, 20 feet away. So let's just practice that now. Just peel your eyes away from your computer screen and look into the farther distance, another part of your house, or maybe you have a window near you, just focusing on something far away. All right. The other part of our wellness break I thought we'd do this morning is just a couple of exercises that can help us maintain our posture. If you're anything like me, you end up looking something like this throughout your day, shoulders up, head forward, and that is just so not what we need. So take a moment now to just push your chair back a little bit, sit up as tall as you can. Imagine that there's a string attached to the crown of your head that's just gently pulling up, creating some space. And we'll start with just some shoulder rolls. So let's roll the shoulders forward, just at your own pace, bringing some movement into these muscles. And then let's roll the shoulders back. And then release. And then we'll do some shoulder blade squeezes. So again, just sitting tall, core engaged. We'll squeeze the shoulder blades together behind the back and just hold for 3 or 4 seconds and release. Squeezing the shoulder blades together, maybe a little bit down your back, like you're trying to put your shoulder blades in your back pockets, and release. Let's do one more, squeezing the shoulder blades together and release. And then this always feels good to me, but please move at your own pace, whatever is comfortable for you. I just like to do a nice overhead reach, kind of stretch, maybe gentle movement, twisting, and then just bring the hands down towards the shoulders. And I think we'll just wrap up our wellness break with a few moments just to sit and breathe, kind of ground ourselves in our bodies. So again, finding your comfortable seat. If you'd like to close your eyes, please do so. And just start to notice what your breath is like right now. How is it feeling as it comes into the body? What does it feel like as it moves out? Does it travel through your nose? Are you breathing through your mouth? How deep into your body is your breath going? And as you start to notice those things, we'll just bring a bit more attention to the depth of our breath. So thinking about expanding the belly the next time you breathe in. And sometimes doing a more audible sigh on the breath out is very relaxing and grounding. So with this next breath in, let's breathe deep into the belly. And as you exhale, make an audible sigh out. And let's do another deep breath. And a big sigh out. And then blinking the eyes open. Just noticing how you feel after a little bit of movement, a little bit of breathing. And if you haven't yet refilled your coffee or gone to let the dog in or out or any of those things you might need to do, just take a few moments to wrap up your break.
Well, thank you, Anna. That was excellent, as always, and I am going to try again to incorporate those moves into my daily routine because it makes you feel so much better. So we are going to move ahead with our program, and we're really excited about the next panel. And actually, I just wanted to thank Anna again before we move on. Thank Anna for participating and offering this wellness break, and also again thank our wellness break sponsor, which is Aging Maine, the Geriatric Workforce Enhancement Program here in Maine. So we'll move on to our next panel, which is advances in using technology to support the health and behavioral health. So we were just talking about social health needs, and now we'll move into technology that actually is supporting the health needs and behavioral health needs. So we've got a great panel coming up. I'm going to again introduce all of them at once, and then we will head on to our first speaker, and I'll let them know who that is. So we've got Mike Charlie, who is the Executive Vice President and COO of Sensio Systems, Inc. Rachel Follansby, who is the Program Clinical Supervisor of Tri-County Mental Health Services. Jennifer Fogel, who's the Vice President of Nursing Clinical Informatics Officer at Northern Light. Leanne Howard, who's the AVP of Home Health at Northern Light Home Care and Hospice, and a late addition, who is Jessica Nalsnick, who's a registered nurse and the Director of Outpatient Care Management at Maine General. So we're excited to have all these folks with us, and we're going to start by hearing from Jennifer Fogel. So Jennifer, go ahead and take it away.
Thank you. And I'm going to share my screen. Make sure I share the right one here. All right. Can you folks see my screen all right?
We can. Thank you so much.
And are you seeing the slide version, not the two-screened version?
We are seeing the slide version, the full screen.
Perfect.
It looks beautiful.
Perfect. Okay. So thank you for inviting me to participate in this panel today. I'm very excited to talk about Northern Lights Health's roadmap to our digital doorway. This is a very exciting, innovative project that Northern Light is undertaking in order to create a digital customer experience. We're really bringing Amazon to healthcare. That's my analogy anyway. So what is a digital doorway? So there is really no standard definition out there in healthcare technology, in the healthcare technology industry today. However, they all have main key points. It's really using everyday technology such as your cell phone or your iPad or your computer to be able to connect with your provider, with healthcare offerings, and throughout your entire journey. It allows early engagement and really provides the best patient customer experience possible. At Northern Light Health, we are in the process of establishing a fully functional electronic mechanism for patients or our customers to easily connect with the services we provide and with our providers. It will be a single platform that is a seamless experience throughout your healthcare journey. It allows us to empower, engage, and communicate with our customers to make sure that we help improve the quality of the care that we deliver. It enhances medical care, and it really increases patient access and convenience. And you can see in the illustration that I have here, you know, someone has their cell phone up and has a number of things, like whether it's a text message or whether they're signing a consent, whether they're participating in a survey about their care, receiving payment information. All of that will be available in that one platform. And really, as I said before, it truly is going to be a seamless experience for you folks. There are a lot of benefits to creating a digital doorway. It really drives consumer awareness, adoption, and engagement in their healthcare. And it's and we understand that it is important to have engaged patients if we're going to really promote preventative medicine and wellness. It allows us to integrate scheduling so that the patient can, for certain things, they'll be able to schedule their perhaps a mammogram or a colonoscopy at a time, place, and location that is convenient for them. It will provide quicker access to care. It will improve their experience, and it does improve both the clinical and the cost of care, because the more you can access things from outside of care, if you are connecting with, closing your care gaps, you're not going to have the extra burden of those finances that may come if you're not engaged in your health care, and really more proactive and frequent touch points, whether it's you with your provider or your provider with you. It will also automate patient education and virtual care. So I'm just going to kind of walk you through a potential journey using the digital doorway. So in this case, Marion learns about a digital doorway. Perhaps it's from social media or a piece on the news or an advertisement of some kind. She receives a text message from her provider's office reminding her it's time for her routine mammogram. She clicks on the link within the message, and that sends her to a site where, again, as I mentioned previously, she can schedule her appointment at a time and place that is convenient to her. She'll receive a text message back regarding any potential out-of-pocket expenses. She'll also receive a link that allows her to complete intake forms, sign consents, participate in surveys that happen prior to the time that she gets to the appointment. That way, when she gets to the appointment, that information is already in her electronic health record. It saves the clinician's time because they're not re-asking the questions that she's already answered, and will really make it a more streamlined experience. She goes in and she receives the care, and they determine that she needs to have a biopsy. From there, she gets into our educational portal where she'll receive pre-procedure education, information that she needs to do to complete the check-in process. Again, all before she comes in for her appointment. Once she has her biopsy, that connection will continue with personalized text, checking in on her, making sure she's filled her prescriptions. Does she have any questions about pain management or dressing changes? And then providing additional education that really are proactive in managing herself and well-being. And the nice thing is she can access the information at a time that's convenient for her. Perhaps it's the end of the day, she's finished supper, the dishes are done, she goes and sits on the couch. She can pull out, her iPad or her iPhone and complete this information or review this information. And then finally, I want to introduce you to our first, the first of our digital doorway offerings that will be going live the end of September with statewide access the end of October. We will be offering virtual walk-in care so that if you have particular needs, you through a telehealth type process, you'll be able to access a provider from Mercy or EMMC or AR Gould are our initial providers that will be staffing this. We expect we'll have providers from all of our 10 hospitals eventually supporting this technology. It will be accessible to all community oh, look at that, there's a typo. Accessible to all community members, whether a Northern Light Health patient or not. And this really does provide some alternatives for care. Perhaps you're an older person who is not driving or does not drive anymore, and you have a rash and you'd like to have someone look at it. You can go with the virtual walk-in. You don't have to worry about getting a ride there. And you can receive your services in that manner. Our providers are using clinical guidelines. There is a national American Telehealth Association who has done virtual walk-in cares for a long time. So we have evidence-based practice and clinical guidelines that will support the types of population of patients that we'll see. There may be some that they call in and they'll be instructed to go to a regular walk-in because it's not the appropriate type of service. But they do have guidelines that will help guide that mechanism. And then the nice thing is it is integrated within the electronic health record. So if you have a follow-up appointment with your primary care physician, that's a Northern Light Health provider, and that you've accessed the virtual walk-in care, they'll have that information available to you at any given time. So I think that's about the end of my time. If anybody has questions, you can put it in the chat, or I'm happy to answer them for you at this time.
There's one quick question. I'm not sure it's quick, actually. But Dr. Renfrew would like to know, do consumers have full access to their medical record?
So within the patient portal already, patients have access to their medical record. There was a law that was put out quite a while ago that allowed healthcare organizations to open up access to their information, and those documents at Northern Light Health are already available via the portal, and that you'll be able to access all of our digital doorway functionality through that portal as well.
And the last question, because we'll move on to Leanne, is how will a patient access the virtual walk-in clinic, which is a really good one.
Yeah, that is good. So it will either be through the patient portal if they're a member of the portal. Otherwise, there will be other means that like the link in the text message. They can just click on the link and it will take them to the website. So there'll be a couple of different mechanisms where they'll be able to access the information.
That's fantastic. And other folks, if you do have questions, please put them in the chat, and I'm sure Jennifer would be happy to answer them. So now we are going to move over to Leanne Howard, who again is with Northern Light Home Care and Hospice. Leanne, take it away.
There. Hi, Leanne Howard, AVP at Northern Light Home Care and Hospice. We are a statewide home care and hospice organization, and we also have palliative care programs as well as quite a few community programs as well. So I know that you've all heard a lot today from others about remote patient monitoring and what that entails. And of course, we've been doing remote patient monitoring for about 15 years, and that has, the offerings and the technology has certainly evolved over the years, and it seems to be speeding up faster and faster all the time. So we have, when you think of remote patient monitoring with a home care or hospice organization, of course, we do have, like everyone else, the blood pressure checks, the oxygen, the heart rate, the scales, asking patients yes or no questions based on their disease, and trying to identify triggers that might be leading to a person having an exacerbation of their illness, and really the end goal to prevent them from going into the ER. So everybody would much rather be treated either in their home or at their physician practice, and really helping our patients to be able to age in place and have not have to access the emergency room or the hospital for that matter. Our remote patient monitoring, in addition to having that technology, because you can have the best technology, but not having a good program to support what you do is really not necessarily going to, you'll have some successes, but it certainly helps to have a well-rounded program. And our nurses that look at our telemonitoring, they have advanced training and certification in things like heart failure and COPD. And we also work with our physicians to have a toolkit of medications that we're able to use to address symptoms. And that's really been part of our success. is having those medications. So not waiting for that call back from the physician practice or a call back from the patient and then trying to get extra medications. So they're all right there for us to be able to use, of course, under the guidance of their provider, and has been really successful. Like many of the others that you've already listened to today, we of course use telemonitoring with our home care patients, but we also have a number of different contracts and agreements with a number of Medicare Advantage plans where we've been able to significantly reduce their cost per member by using a program like this. And so one of the things that I talk a lot about is when we all know who these patients are, they're patients that we call them sometimes our frequent flyers, or those patients that we continue to see time and time again, and it seems like the same story, right? But with our program, what we found that we've been able to do is those events that were happening that would bring that patient back to home care, so a hospitalization or an ER visit, we were able to prevent those from happening. So for our Advantage plans where we're telemonitoring a patient, they're not even receiving home care, they may be out independent in the community, but through remote patient monitoring, we are able to see the change in their activity or the change in their weight, change in a blood pressure, any sort, or even their symptoms. And then that leads to a whole chain of events that happen for us to follow up with them and their provider. And then many times we're admitting them back under home care and we're addressing their increased acuity. They're now not able to leave their home because of symptoms or whatever they're experiencing. So we're able to provide that care in the home. And what we've done is prevented that visit to not only the high cost center, but the high anxiety and all that patients go through in their families when they have that ER visit or hospitalization. And so we've been able to prevent that and get them the help they need. The other thing that helps us to do is to use as a tool to identify and make sure that patients are receiving the care that's right for them. Many of our patients are end stage in their disease process and really benefit from the hospice services, or they really have their goal of care for what they're dealing with is really a palliative approach. So just helping to help them figure out where it is they are, what they want, and then what services can we help provide for them to support their goals. And so many times that I tell my staff is make sure what our goals may be for our patient may not be what their goals are. So definitely using this as a tool to have those conversations with our patients. And again, many of them are home care and hospice services, but many are seen under our Advantage plan contracts, which we've been really successful with decreasing their cost per member with. And then, also with what we consider telehealth and helping age in place is our PERS program. So that personal emergency response, and you think of it as a fall button. And so we actually provide this service to the entire state. It's not just, we have home care services pretty much throughout the entire state, but our PERS program, which is called Live Safe, is throughout the entire state. And bringing an option to patients that is local. We have technicians that install that equipment, and that's really helpful for a lot of, especially our seniors who are anxious. How do I set this up? How do I use it? What does this mean? And if they have trouble with the equipment, we have a local on-site person who can answer the phone, can walk them through how to troubleshoot. And if there is still an issue, we'll come to their home and check things out and make sure things are going as they should be. And many times patients will have both remote patient monitoring and the on Live Safe, or they may have one or the other. With Live Safe, our Live Safe program, we also do a number of caring calls and just following up with them. A lot of times it is just social needs that they're looking for and just somebody to talk to. But also we've been able to identify where things maybe weren't going as well as they could be, and then helping to support that patient to get plugged in with the the person, the provider, or whatever it is that they needed. Like most remote patient monitoring programs, we also have the ability to do video visits. And we do those, of course, with the patients and our nurses or our therapy group, but also with their provider, with their family member. A lot of times providers look to us to do that home visit and to do a video visit with them, because we're able to do that assessment while the patient's in the comfort of their home, decrease that anxiety, decrease their risk of picking up something while they're out and about. And that's been really helpful. Our accountable care organization that's connected with our health system, all of their care managers have access to the readings that come in, to the patients that are attributed to the ACO, as well as care managers for any of our Medicare Advantage groups. They have access to their patients. We do case conferencing with them at least once a month, sometimes twice a month, just to make sure, you know, I always say we have tons of ways to communicate, but it seems the one thing we all wish we could do better is communicate. So having those meetings, talking about patients, what's going on, and taking down those barriers that we've probably all experienced in our access to healthcare. So really quick overview, happy to answer any questions. But thank you for the opportunity to speak to you all.
Thank you, Leanne. It's awesome. That's great stuff. And again, if you have any questions for Leanne, please put them in the chat. We're going to go ahead and move on to our next presentation, which is sort of a joint presentation with Mike Charlie. He's starting, and he is, again, the Executive Vice President and Chief Operating Officer of Sensio Systems. So take it away, Mike.
Okay, I don't know, can you hear me? Oh, there we go. Okay, great. Good morning all. And again, thanks for the opportunity to share here. My name is Mike Charlie. I'm the Chief Operating Officer of Sensio Systems. I'm going to go rather quickly here because, as Jess mentioned, I have a partner that's from Tri-County Mental Health Services that's also going to provide some information and insights to the great things that we're doing together here. So I'm going to kind of rip right through this. But Sensio Systems is a Massachusetts and Maine-based company. We providing the IBIS Health System, IBIS Health Program to eligible members in all of New England, well, in Maine, New Hampshire, and Massachusetts currently. Our program is basically a self-management support program. It consists of an AI-based technology that goes in each individual's home that provides them with a daily care plan and a daily task plan, along with a set of services that include non-clinical services through our member advocates who establish relationships, communicate routinely with our members. And when they see a member beginning to have some struggles, either in keeping up with their tasks or just indicating that they're having some challenges, we reach out, particularly on the isolation and loneliness piece. It's been very beneficial here during the pandemic for those that are living independently. So our focus is on those who have the most complex health issues and are struggling to live independently. I'll talk a little bit more specifics about the population in a moment, but the technology is combined with a set of services, a non-clinical service, our member advocates, which are the ones who communicate regularly with our members. We have our RN level of support that can be used as an advisor to our member advocates or to our member to provide them with information or to get a better understanding of what might be developing into a clinical issue. And we also have a set of nurse practitioners and physicians that, again, can provide oversight to understand exactly what is going on in the home 24/7. And we really are an extension. We serve as an extension of an individual's normal care team. We don't replace a primary care physician or specialist. We really act as an extension to those. And what we provide, two things to the normal care team. We provide real-time situational awareness in the home 24/7, and we provide an engaged patient. And by an engaged patient, I mean we coach, we encourage, we understand what's going on with the patient in the home. We can help tell the patient this is a time you need to reach out to your primary care physician, or perhaps it's not a time. Let's try and work on this ourselves. And our real focus and our belief is that most people want the opportunity to help take care of themselves. Most people want to continue to live independently, and a good share of the population, this vulnerable population, can in fact help manage and support themselves if they're given the tools, the knowledge, and the reminders to be able to do that. Okay, I'm going to try to share my screen here now. That's a very brief overview. And let me see if I can make this work. So okay, so my screen is up, I believe.
We see it.
Okay, great. So the population that we're really focused on are those with the most vulnerable populations, those with the most complex care challenges, who continue to try and to live independently with the best quality of life that they can. The majority of our members are all 65 and over, have multiple chronic conditions, and have some have caregivers in the home, but many live independently and are just trying their best to get along. I think we all understand the challenges with this population. The individual themselves frustrated with trying to keep track, supposed to do. As an example, our average member, we call it the participants in our program members, obviously they're patients. Our average member takes about 18 medication doses a day and has about 24 to 25 activities that they should do each day. That can be anything.
Mike, we've lost you.
Okay.
There you are. You're back.
Still not, okay, sorry about that. But anyway, a very complex population that again just becomes frustrated, and too often is it just gives up because they are overwhelmed. And then of course they begin using emergency care for exacerbations or for help. At the same time, the physician on the other end are obviously challenged with high need patients that need time, that they don't have necessarily the time to provide all the things they need. Everything this member needs isn't necessarily clinical that a physician or a clinical person would need to do. One of the things our program does do is we combine the physical health, the mental health, and also the social needs of individuals. Most of our members have all of those kinds of challenges. And so the opportunity is here for us to integrate, using community-based partners, integrate the three areas of care to provide the best quality of life for individual, as we can see. Basically, the platform, I'm going to try to demonstrate it here in a minute, is a tablet that goes in the home. It has a dynamic daily care plan. By that dynamic, it means it can change regularly as things emerge that they need to change, whether it's a medication change or a change in activity of daily living or change in meal times, whatever that may be. And there's also a self-recovery workflow I'll talk about here just momentarily that helps them manage their way through many of the challenges that they have. This is just a couple of screenshots. I'm going to demo the system here in just a moment, but basically the platform itself has this personalized daily care plan. It has activity reminders and coaching. The program includes both the tablet, any peripheral devices that are indicated as necessary, blood pressure cuffs, weight scales, glucometers, pulse ox, whatever that particular individual's health status requires. We also, as part of the program, provide those peripherals, and we provide internet connectivity if they don't have it, and that all goes along with the program. We have a coordinated billing service. I'll talk about just a little bit here at the end for our partners that help provide the services that the individuals may need. And we have a set of self-recovery protocols. So when the system recognizes an emerging health exacerbation, not only will it notify our staff so they can begin to assist, monitor, and then assist as necessary, but the program, the device itself will begin to walk a member through what their pulmonologist or endocrinologist or whomever may want them to do to help mitigate any emerging issue. Okay, I'm now going to attempt here, if I can, and with Krista's help, to I'm going to stop sharing this screen, and I'm now going to go to the tablet, if that's possible. Here we go. Okay, I believe you can see my screen now.
Yes, we can see your screen.
Okay, great. So this is the device. This is the screenshot that what a member sees on their device. You will see very nice large icons, which is important for our population. It's basically just an interactive screen. As you can see, I'm behind on breakfast this morning. I just interact here. It gives me a nice little morning greeting. It reminds me of my meds throughout the day. Part of our service, there's a photograph of each medication that they're to take at the time. If they have a pill pack, however, it will just say, take your meds. But if they're taking individual medications, it will show a photograph of that med. So if it's a new generic, they'll know it's still the same one that they're supposed to take, and all of that is good. Reminds them to take meals. We have partnerships ongoing right now with the Eastern Area Agency on Aging, and we're getting one set up with the University of New England on diets and for diabetics and so forth, and to do some analysis on the value of medically tailored meals. So we'll have the opportunity to do that. Variety of activities of daily living. Reminds them if they have an appointment that they're to go to their appointment today. And obviously this is preceded the day before. One of our member advocates will call the individual and say, remember, you have an appointment tomorrow. Your driver is going to pick you up a little bit ahead of time, or your daughter will be there, whatever it is, to make sure that they're still involved with that. We have about 50 activities of daily living: feed your pets, clean the refrigerator, do your laundry, change your clothes, all of those kinds of things, again, that many people can do if they have the opportunity to and can be reminded of that. A variety of basic questions. These self-checks are the things that we usually learn the quickest that someone is going to have an exacerbation. The AI sits behind this, so no one has to sit and look at this data, but I can set this for Mrs. Jones as example to know that if her mood changes by 2 increments there, that's usually the indication for her that's an onset of a potential exacerbation of health. And therefore that we can set it so the member advocate will call, see what's going on as necessary, being able to refer that off. I'm not going to spend too much more time here on these. We have a variety of ways that individuals can reach out and communicate. They can simply send a text here if they so desire. They could do that, or they could just tap like that, and as the member advocate will now be getting the note saying that Mrs. Jones would like to be called. We have a great rewards program here. That's just a little thing that we help to motivate and incentivize our members. You can see this is my demo patient. I've been doing really well here, and I've been hogging all of the trophies here, so that's kind of exciting and nice. We have a variety of games. I'm not going to demonstrate this because Jess and Krista and people like that who know me realize that could take some time for me to actually be able to complete that game. So I'm not going to demonstrate that. But the reason for those games can be entertaining, and that's fine, but that's also an opportunity to begin to understand cognitive decline. issues among a patient, the AI will measure how long it takes someone to complete the game, how much they complete the game. When it begins to fall off again, the system can notify the team to start looking and taking a look to see what may be the challenge. Okay, with that said, I'm going to I'm sorry. Also, a very large educational opportunity here. You can put videos on here, training videos. You can have recipes, a wide variety of things that can go on here. So now, if I can get off of this screen, I will do so. And just quickly, I'm going to go back to my other screen here now, Krista, if you can keep up with me. I'm trying to lose her, but not. She seems to be doing a very good job here. So, so just in very quickly here, we've been operating now in Maine for about 6 years. We've had about 1,000 members, Mainers on the system over that time, about 800,000 patient days. We've done several projects. This is some of the results of with one of the partners that we've done up there, and you can see we've had significant success in reducing ER visits and reducing admissions, 0 readmissions with this particular population, which were all duly eligibles, by the way. So very, very impressive and rewarding and satisfying results there. And finally, I'm going to turn this over in a second, but we have established partnerships with numerous partners in Maine. Some of those are folks who refer their patients, or a lot of housing activities there who can help us get their members on board, because it helps stabilize their living conditions, reduces churn for the housing environment, and helps people to continue to live independently. We have another set of partners who actually are community-based and provide necessary services for our members. We're partnered with Bedard Pharmacy, who provides pharmacological reviews for us for all of our members, and a couple of other groups up there. But we're also partnered with Tri-County Mental Health System, and I'm going to turn it over here in just a second to Rachel, but I will just say a couple of things about the program in general. It's highly scalable because it greatly can extend the reach of the workforce and extend the efficiency and effectivity of the workforce. And it's also very affordable because it's a Medicare paid benefit. So there's no cost to the member. All supplemental insurances are paying the co-pays for the duly eligible. And we're currently just recently credentialed with Martins Point, with Anthem, with Humana. We're finishing with Harvard Pilgrim now, with United Healthcare. So we're also going to be available to the folks that are using the Medicare Advantage program. So with that now, I don't know if I'm going to turn it back to Jess here to move on, but that's in very quick overview of where we are, what we do. Happy to answer questions or field any calls or whatever. So thank you.
Well, thanks, Mike. And I think we're going to hear next from Rachel Follansby, who's working for Tri-County Mental Health Services as a program clinical supervisor, and is working with the Sensio system team. So I'm going to turn it over to you, Rachel.
Hello, I'm Rachel. I'm a program clinical supervisor at Tri-County, and I'm also the screening clinician for Sensio. My role with Sensio is to connect with the members by phone, and I do a brief screening for depression, anxiety, and safety. These screening tools can also be added to the member's tablet that Mike just went over. If their needs suggest that they would benefit from outpatient counseling, then I discuss the services with them. And if they're in agreement to it, then I'll just make a referral to one of our Tri-County clinicians. Since I've started, we've been able to get them in for services within 1 to 2 weeks, and they're doing their counseling by phone. And just recently, we've got more of the members who are doing it by telehealth. Some of the members are 1.5 hours to 2 hours away from the provider clinician, so it's been really good to bring that service to their homes and not have to have them travel. If there's any other needs that I identify in the screenings, then I follow up with their member advocate and do what I can, and then they take care of whatever they can. Since I started working with Sensio, and Tri-County has, response from the members has been great. They've welcomed the calls. They've been very appreciative of it. I found that during the height of the pandemic, the screenings for depression and anxiety were much higher, and the demand for services increased, and also the demand for, with the demand for services increasing, there was just not enough providers. So this allowed some of these members to get into services very quickly. I found that since our collaboration has started, we've increased the ability for the members to access outpatient counseling from their homes. Some of them can't leave their homes, some of them don't want to leave their homes. And then when everyone was quarantined, we really didn't have that option for folks to leave their home. They're also not having to travel to the providers, and we are delivering the service to them. That's just a quick summary of my role. So I'm happy to answer any questions with that as well.
And Jess, if I might be able to just add two more quick points here. One is about our members themselves. We have been very, very pleasantly surprised at the demonstrated ability of our population to use the technology. Too often we kind of tend to think that, well, you know, they've never had a computer, they don't have a cell phone, or if they have a phone, they can barely figure out how to use it as a phone. We have had significant success, and it's a highly rewarding thing for most of our members. The number of times our member advocates here, you know, my daughter said I could never use a computer, and I showed her I'm using a computer. And it's that self-confidence, that it's kind of an uplifting of the spirit and all, and it's absolutely, don't watch my aviator language here, it's absolutely debunked the myth that the elder folks just, you know, they'll never get it and they can't use technology and so forth. We put in a ton of time coaching for those who need and walk it through, but they can do that. The second point I would make, again, we're not interested in providing all of the services that can be provided through our program. What we're interested in doing is integrating those community-based organizations who already do a great job of providing those services, but allow them to do it at the right time and in the right place. And for those partners I mentioned, and for those that work through the IBIS program, it also gives them access to some additional revenue stream that they wouldn't normally have. And oftentimes it's some revenue for things they already do because they know it just needs to get done, and they're doing that. So we welcome all of the partners that we can find, and would love to have more that participate in supporting our elder Mainers. Thank you. Thanks, Jess. Appreciate it. Thanks, everybody.
Thanks to both of you, Mike and Rachel. And Mike, there is a question in the chat. I'm going to ask you if you wouldn't mind just going ahead and answering it, because we do have to just move on to our last presenter in this panel.
Sure.
Great. Thank you. So we now will hear from, again, Jessica, excuse me, Nalznick, I'm hoping I'm saying that right, who is the Director of Outpatient Care Management at Maine General.
Hi, good morning. Thank you for the invitation. So I will be rather quickly. As Jess said, I am the Director of Outpatient Care Management here at Maine General. And along with Andrew Scoggin, we are utilizing remote patient monitoring with the same company, which is HRS, Health Recovery Solutions. We started, we had back in the day, folks may remember they called it the Turtle. So we did have remote monitoring probably close to 20 years ago. But we started back up of January of 2020. So we're just shy of 2 years in. And similar to Andrew Scoggin as well, we do not require folks to be open to our home care agency. So we've been able to extend it to many more patients. Again, she kind of went over the monitoring pieces, the quizzes, the education. Our goal is to monitor patients for about 3 months. If they do have an admission during that period, we kind of hit the reset button and monitor for another 90 days. another kind of advantage we have is we have some funding. So we've been able to purchase equipment when patients are done with monitoring. We're able to provide a scale, a blood pressure cuff, and pulse oximetry if patients don't have the means to purchase their own. We currently have about 155 patients actively being monitored today, and we've monitored about 400 over the last, just shy of 2 years. Our primary focus remains CHF and COPD. I'm proud to say in the last, like I said, 20 months or so, we've only had 3 patients that were on RPM that were readmitted with CHF out of 45 total. So we've definitely seen some good outcomes. Looking at our COPD readmissions, we've not had a single COPD readmission for patients that are on monitoring. I think that's it, just because folks really kind of covered it well. We're just really focusing on any chronic condition. We have folks on for hypertension, pneumonia. We've had, unfortunately, numerous on for COVID, and patients have found that pretty helpful, just knowing that there's a nurse on the other end of that line. So when they answer their question in the morning, would you like a nurse to call? They select yes, they will get a phone call. We're able to monitor blood sugars for diabetics, activity, and we are hopefully looking into purchasing another, it's a stethoscope device, but it will allow us to do EKGs on patients as well. So great program. That's it for me.
Excellent. Yeah. Thanks for joining, Jess.
Of course.
One of the new Jesses. We have a lot of them. Thanks for joining. So now we're going to move to something totally different. And this is pretty exciting because UNE has actually been engaged with this work for a number of years. And so we're excited to be able to highlight it. Next up, we're going to have a special presentation that features using technology to build empathy in health professionals. As I think you know, we don't have enough health professionals in Maine just generally, and we certainly don't have enough that are focused on geriatric care. And so one aspect of education for providers is to connect them with training and educational tools that can help them build empathy as they're providing care for older people. So I'm going to turn things over to Marilyn Gallucci. She is an MA, PhD professor and director of geriatrics research at the University of New England College of Osteopathic Medicine. And she is also a founding member of the Maine Council on Aging and our board secretary, and has been our board secretary since the very beginning. And we don't know what we would do without her. So Marilyn, take it away.
Thank you, Jess. So I know that time is brief, so I'm going to jump right in here. We have been using virtual reality for a number of years now, and what I'm going to do is take you through that. And virtual reality is actually very interactive and quite believable. And we're working with Embodied Labs, and I want to just state that I am on their advisory board. I am a non-paid member on their advisory board, and have really been working with them to use, to reframe their language, move away from elderly into older adult, older person. So I've really enjoyed working with these people. The key is that oftentimes health professions students, we have 17 health professions programs, and health professionals and providers and service providers in the field are really experiential learners by and large. And so to be able to put on this headset that you see on the right and to interact with a program so that you feel that you are there physically and emotionally is really what creates the learning. In terms of our findings, and we've done this with a number of the labs, pre-post, we have not done longitudinal. We don't know if it sticks. But in terms of pre-post virtual reality experiences, we find that definitely there's a total significance, off the scale significance, in terms of students feeling that they can understand and share the feelings of the person that they embody. And I'll say a little more about this in just a second. This company, Embodied Labs, this is Carrie Shaw and her mother. Her sister, Erin Washington, is also a co-founder of Embodied Labs. Their mother had early onset dementia. They were both incredibly frustrated because when people would come into the home to help their mom with meals, they just couldn't, oops, I don't know why that's moving. They just couldn't, the providers couldn't really understand what the mom was needing. And so Carrie actually designed these glasses because her mother's field of vision on one side was totally not there. And so she could never eat the food on that side of her plate. And Carrie made sure that all the healthcare providers wore these glasses when they were working with their mom so that they could understand a little more about what was happening. And that, again, that experience of being there and wearing these glasses made a difference for these healthcare providers. They then moved into creating Embodied Labs and creating virtual reality. The first one is the Alfred Lab. It's only 7 minutes long. You actually embody Alfred. He's an African-American male. He's 74 years old. He has a macular degeneration and he has high frequency hearing loss. And I'm going to just show you a 30-second clip. This is 2D, realizing that when you have the headset on, you can look around 360 degrees. One of our librarians did this segment for us. Here you can see Alfred's hands. You will see her hands moving. They will be the hands of an African-American male. Here is macular degeneration. So let me just have you experience that. The sound will be muffled. There's your macular. Show her hands soon.
Happy birthday, dear Alfred. Happy birthday to you. Happy birthday, Pops.
I love you, honey. Happy birthday.
Make a wish, Grandpa.
So as that segment goes on, what happens is that you eventually get hearing aids, and so your hearing clears up, but you can truly understand how frustrating it would be to have macular degeneration. And for people that have it, to explain it is really difficult, but for you to embody Alfred and go through that experience is something that can really bring that to fruition in terms of what that must feel like. The next lab they did was the Beatrice Lab. It's a progression of dementia. There's 3 stages to it. Each one is about 7 or 8 minutes. And it takes you through the early stage, the middle stage, and the late stage of a Hispanic woman. Then with the Clay Lab, actually they flew to Maine, and I put them in the Gosnell Memorial Hospice Home for 48 hours, project that I do with students, so they could really understand end-of-life care and they could live it, so they could create this lab. And so Clay is a 66-year-old male, and the 3 segments of this, again, each segment is only 7 minutes, so it doesn't take very much time to experience what it's like to die, actually. So Clay receives a terminal diagnosis. He then transitions to his home for hospice, and then his last days, and he does die at the end. So, and there's postmortem care. So to embody this is really quite powerful, and we suggest that you make sure there's platforms for communicating with people if they actually go through this lab. The DEMA Lab, again, we had one of the co-founders and a scriptwriter come to Maine, and I actually admitted them for 48 hours into a dementia care unit in a nursing home so they could really understand about Lewy body dementia, Parkinson's disease. And in this one, Dima, a Muslim woman, actually transitions from home to a community care, pretty much a nursing home care. And so by them flying to Maine and staying in a dementia unit was pretty amazing in terms of the amount of learning that they want to do. This one, again, is powerful in that hallucinations, you would feel what it's like to have hallucinations, and it's really startling. One of their newest labs in the past years, an Eden lab. It's on trans health and LGBT health. Eden actually was born Edward and in the 50s, and then it shows his transition into an older adult trans female. And then there's other segments to this that go over LGBT health, housing, and social support. The two newest ones are the Frank Lab, which is social isolation and loneliness. Again, you get to interact as Frank throughout this lab. And their newest lab that just came out this past month is elder safety and well-being, caregiver burnout, trauma information, and de-escalation. So it really takes any of the health profession students or service and health providers through each of these. So that was a whirlwind tour, and just a reminder that we have our 30th annual Maine Geriatrics Conference, June 9th and 10th. We hope to bring this virtual reality platform with us. We do have it at both our libraries in Portland and in Biddeford. And if you're interested in trying it out, just get in touch with me and we can make an appointment for you to visit the library and experience some of these labs. That's it, Jess.
You are fantastic. Thank you so much.
You're welcome.
And it's always good to see you. So our final presenter today is Nancy Smith. As you know, COVID has really laid bare this reality that whether you can access all that technology has to offer depends on whether you have access to broadband and whether you have access to the technology itself. And this is creating a real system of have and have nots. And we saw that just so acutely over the last 18 months. So thankfully, there's a lot happening nationally and in Maine to solve this challenge. And we've asked Nancy Smith, who's the Executive Director of Grow Smart Maine, to let us know how we can effectively become engaged and even effectively advocate for these issues. So now I will turn things over to Nancy.
Thanks so much, Jess. I am Nancy Smith, Executive Director of Grow Smart Maine. Going to make sure you can all hear me okay? All right. I see in the attendees today professionals, community volunteers, and elected officials, all essential in making things actually happen. Grow Smart Maine, if you're not familiar with us, is a statewide nonprofit. Our mission is to build lasting prosperity without sacrificing the quality of place that defines Maine. We do our work through events like today, as well as through community engagement and advocacy. Smart growth principles address the changes that are needed and the challenges that go along with aging in place, aging in your home, as well as aging in your community. You can do advocacy and you will make a difference when you do so. All of the potential and the values that we've heard today, and I've been on for most of the time since 9 o'clock this morning, listening to this potential, require local voices to make them happen. And advocacy is the way for that to become real. So whether it's looking at the use of federal dollars, and we're hearing more and more about that, or policy issues. And in general, policy is wonderful, but until it's paired with the funding, it doesn't come into effect. So you need to look at both. I provided 2 resources to the to Jess and to others that will be shared after the conference. One is a list of links, how to find elected officials that you want to have an impact with. And one I will share now in the chat. You give me just a sec. Grow Smart Maine does a series of community guidelines, how to help you achieve some of the goals that we can all share and believe in. So in the chat is this community guide for local outreach and advocacy. Well, if you want to open it now and go along with me, that's terrific. If you would prefer, I'm just going to run through the 7 key points and you can take a look at it later. First, when you're talking about advocacy is simply making your point heard and trying to influence someone else's decisions, behaviors, and attitudes. What is your goal? when you start with advocacy, you need to be very clear on what it is you want to achieve. More specifically, what are you asking the person or the people you're talking to do? Be sure that you make a clear ask and provide them with the information that they'll need to make it happen. Think too along these lines of who your audiences are. Traditionally, in my work, it would be elected officials, but for you, it may be your doctor, asking your doctor to take part in some of these amazing tools. It may be your family, either in supporting you or people that you're supporting that you want to understand this. When you think about who your audiences are, it may be people who will directly benefit from the proposals that you're making. It may be those who are not inclined to support it, but you want to have a conversation with them. It may be people who want more information. Rarely is your audience people who are already dead set opposed to what it is you're asking for. It's simply not worth your time, and you need to focus where you can make a difference. There are exceptions, but in general, think about whether it's going to be worth your time to try to influence someone who's already made up their mind. For reaching each of these audiences, there are 3 considerations. What message will work the best for this group or this person? You'll want to appeal to their interests and their concerns. We're all human. We want to know what's in it for us. That's perfectly legitimate, and you should build on that in your conversation while remaining true to the overall message. Always be truthful, and again, be very careful about where you go negative. I don't think negative is effective, and I think it's exhausting. But that's what you think about for the message that will work. Another point is which messenger may be most effective. If you're talking to your doctor or your family members, you may not be the strongest messenger for this person. Who do they trust and who do they relate to? These are things for you to think through. And then finally, what communication tools will work best for each audience? And again, this is about them. Where do they get their trusted information? It might be an email, it might be a phone call, it might be social media, it might be reaching out to a newspaper and asking for a news story. Earned media is very effective in highlighting the credibility of the point that you're trying to present. Meetings, go to theirs as well as ask for their own, and then personal visits. Rarely, but sometimes you might be interested in paid advertising, but normally that's not what I'm thinking for this group today. And then a final piece of advice is who has been where you are? Who can you go to get advice? And what did they learn? What can you learn from them? And then of course, I'll flip it. Once you get very comfortable with advocacy, what can you do to help others who are coming up behind you? Along these lines, I would urge you, if you're not already, to become a member of the Maine Broadband Coalition. That link is in the list of resources I've shared. You can also just type in mainebroadbandcoalition.org. Grow Smart Maine is one of the original members. We're on the advisory council, and I co-lead the policy work that we do. This is an opportunity to be up to date on what's happening, to learn and have support in advocacy to your elected officials, but they're also doing regional dialogues. As we're looking at this federal money coming in that's out on social media and in the newspapers today, how do we get counties and municipalities in the state to coordinate on all of this effort that's happening? The Maine Broadband Coalition is working very hard along these ways. So to close, decide what you want from the person that you're advocating with. Decide what stories and what data will influence them. Some people are moved by the heart, some by the head. Usually we need a little bit of both. Make a direct ask. It's okay to say, I want you to vote for, or I want you to fund. Let them know exactly what the ask is. Share your contact information so they can follow up with you. And then finally, speak once, but build on that effort. If you have a phone call with an elected official, write a letter to the editor and say, I had a conversation with this elected official and here is the outcome. If you do it once, there are easy ways that you can amplify that and get more impact. The other thing to do when you have a conversation with someone, particularly an elected official, tell your friends and family, if you do it, you empower them to do it because it's intimidating. Now, I served in the legislature for 8 years, and I learned that going to the grocery store takes an hour because you're going to run into people who want to talk to you. It can be challenging. It was also one of my favorite parts of this. But when you share with the people in your daily life that you've done this, it makes it real for them to do it as well. That's a quick summary of advocacy. I encourage you to look at the community guide that Grow Smart Maine prepared. Happy to share it with you today, and then it'll be part of the links that goes out with the summit afterwards. And I'll see you all at the big summit coming up later this month. Thanks very much.
Thank you, Nancy. And does anybody have questions for Nancy before we move to our closing comments? Great information. Really nicely put together.
Thank you.
All right, so then thank you again to all of our terrific presenters for their contributions today and for all of you joining us. I don't know about you, but I'm really looking forward to the day that I can call a virtual nurse up on my tablet and ask if I need to go to the ER because I, cut my finger cooking or something like that. I'm excited about that. So for our final part of today's session, we'll be inviting you to join our live exhibitor lunch and learn presentations. As we've had to move everything to virtual, one of the things we've tried to figure out is how we can help our sponsors and exhibitors have more interaction with attendees. So we've devised these short lunch and learn presentations as one way, and they will be happening throughout our summit segments. And these are optional, but we really do encourage you to join one of the sessions to hear more from our sponsors. And we've got two great presentations lined up today. One is on telehealth by Andrew Scoggin, home healthcare and hospice, and the other is tech-enabled health stories by Sensio systems. Before we send you off to the breakout rooms, we've got a few reminders. Today's event was recorded and will be shared with registrants when it's ready, as well as the presentation materials. We also encourage you to visit our exhibitor hall. It's pretty cool. It's way better than last year. I mean, really better than last year. And we've got a lot of exhibitors. So we encourage you to visit them early and often. And then finally, we encourage you to take the evaluation that we'll be sending right after this event. And so that would be great if we could get some feedback from you. We'll also be asking what other topics you might like to hear about in the future. We want you to join us for next week's pre-summit session on embracing job quality for Maine's essential support workforce. That's happening at the same time next week on September 14th. And then, of course, we really would love for you to join our big summit day on September 21st. And if you haven't registered for those programs, registration is still open, and we encourage you to please join us. As just a quick reminder, all of our events will be recorded, so even if you can't join live, you'll be able to gain access to the recordings once the presentation is over. So a big thank you again to our sponsors for making this summit possible this year, and to our exhibitors and to our presenters, to our planning committee, and to all of you. I hope to see you next Tuesday for our workforce conversation, or on the 21st for our big summit. And now I think we will turn things over to Krista, who will explain how this lunch and learn exhibitor presentation is going to work.
All right. Yes, thank you, Jess, and thank you everyone for joining us today. I hope you've enjoyed today's session. We've got some great presentations lined up today from Andrew Scoggin and also Sensio Systems. So I just wanted to give you all a moment. If you haven't used breakout rooms before, there's a little icon down at the bottom. We will go ahead and open these rooms, and we will have you go ahead and select the room that you'd like to visit, and hope that you will enjoy the presentations. So thank you all, and we hope you have a wonderful rest of your day. And then if at the end of this, if you're all done after the presentation, you're welcome to come back to the original room or leave right from the presentation when it's complete. So thank you all.